A warm welcome to everyone. Warm welcome to the third episode of the Indian Orthodontic Society's international webinar series, Illuminati. iOS brings you luminaries from around the world to your smart devices and laptops on every Saturday at 7 p.m. And as I told you earlier, this is the third episode of this series. And today we have a master clinician from Ecuador, Dr. Yuli Moncayo. Welcome, Dr. Yuli. And I would also like to heartily welcome the principal office bearers of the Indian Orthodontic Society, the president of the Indian Orthodontic Society, Dr. Silju Matthew, and the honorary secretary, Dr. Sridevi Padmanabhan, the members of the executive committee, and all the orthodontic fraternity that has gathered for this webinar. And without further ado, I would like to invite the president of the Indian Orthodontic Society to address this gathering.
Thank you, Dr. Siddharth, and a warm greeting to one and all the distinguished members of Indian Orthodontic Society, Madam Secretary, the principal office bearers, the EC members, the senior members, and dear friends. Welcome to the third lecture of the iOS International Webinar Series, which has become quite popular among the members, wherein we bring the top orthodontic clinicians from across the globe to share their experience as explained by Dr. Siddharth. Today, we have Dr. Yuli Moncayo from Ecuador. A warm welcome to you, Dr. Yuli Moncayo, to the iOS webinar series. And it's great to have you here. And we look forward to learn from your experience. And the topic that she would be speaking is 3D diagnosis and treatment planning, an aesthetic approach to modern biomechanics. Dr. Yuli completed her basic dental education from Ecuador, and she moved on to Buenos Aires, Argentina, where she completed a master's at the University del Salvador, and she is presently based at Ecuador. Now, I welcome you, Dr. Yuli, and look forward to an evening of great learning from your experience. Special thanks to all the conveners of today's event, Dr. Siddharth Shetty, Dr. Swati, Dr. Divyaru, and of course, the people who are behind the show, Dr. Sanjay Lab and Dr. Sridevi Madam, for coordinating the event. Special thanks to you all. So look forward to a great evening of learning, and thank you all. Jai Hind, Jai Avas.
Thank you, sir. Thank you. Thank you. So before starting any proceeding, as our Indian tradition, we do the lamp lighting.
Shubham Kurutvam Kalyanam Arogyam Dhanasampadah. Shubham Kurutvam Kalyanam Arogyam Dhanasampadah.
So I request Professor Sridevi Padmanabhan, ma'am, to kindly introduce the speaker and start the program.
Very good evening to one and all. It's a pleasure to introduce such an accomplished speaker. She's very modest. She's sent a very, very brief CV, but I know how erudite and how accomplished she is. She passed out from the University of Guayaquil, Ecuador, and she's a specialist in orthodontics and maxillofacial orthopedics. And she's certified in numerous things like Invisalign, Lingual Orthodontics from Harmony American Orthodontics, 2D Lingual Orthodontics, micro implants and temporary anchorage devices, Damon, and she's certified in lots of other systems like the AT system certification, mini plates anchorage and 3D diagnosis. She's an active member of the Society of Orthodontics and Orthopedics of Guayas, the Ecuadorian Society of Orthodontics, the World Federation of Orthodontics, and she lectures extensively nationally and internationally. Not only that, in addition to her orthodontic accomplishments, we know that she's a fitness enthusiast, and we have been delighted by looking at her pictures of her practicing yoga. So I'm sure sometime we will have you back to teach us yoga too, Dr. Yuli. It's a pleasure to have you here, and we look forward to your lecture and to you sharing your experience and your expertise with us. Welcome.
Thank you.
Thank you, madam. Thanks a lot. So as our knowledge partner is OMCO for this event. So Dr. Yuli, by the time you can prepare your system. So now the screen is going to be yours.
Okay, so I could share now?
Yes, you can share up just after this. Few seconds. Okay, you may please share your screen. I stopped sharing my screen. You may please share your screen.
Okay. Okay, so it's, can I start now? So
Yes, please.
Yes, please.
thank you. Well, thank you very much for this invitation to the Indian Orthodontic Society. It's an honor for me to be with you again. I was in India last year, and I had a very wonderful time. So now being here for me is like very comfortable. I feel like I'm with friends, and I appreciate this very much. So thank you for this invitation, doctors. I am very glad to be here. I had a very wonderful time last year. So I hope you enjoy the lecture. I want to share with you a little bit of what I do in my private practice. As we were speaking before the lecture, I do a lot of clinical work. I'm not that much into investigations and that kind of research, but I can share all my work that is mostly clinical work. So the lecture of today is about 3D diagnosis and treatment. I've been working a little while with 3D, and I found that 3D is a very special tool that we have for our diagnosis. So I want to share a little bit of how we can manage our treatment plans with 3D and an aesthetic approach to modern biomechanics. Nowadays, aesthetics are a very important part of our work, and we can accomplish a lot of great results combining this multidisciplinary work. So thank you for the introduction, and I want to share a little bit before we start about my country. As the doctor well said, I am from Ecuador. I live in a little country, is very small in South America. We live in the middle of the world. That's why is the Ecuador the middle of the world. So I like to share this video. Maybe, I don't know if you've seen it, but we have 3 different stations on our country. So we have the Pacific coast, that is a very warm place, and the beaches, and the highlands, that is in the middle, that is a very cold weather, and the Amazon, that is like more like jungle, if we can say, and the Galapagos Islands. So I want to share this with you. I hope you like it. A little bit of my country. This is in the highlands, the mountains in Ecuador.
All you need is to try.
That's the Quilotoa Lake. It's a very wonderful place. That's the Amazons.
All you need is to disconnect. All you need is to feel.
The beaches where I live is always summer.
All you need is to escape. All you need is to share. All you There's nothing you can do that can't be done. Nothing you can sing that can't be sung. Nothing you can say, but you can learn how to play the game. It's easy. Nothing you can make that can't be made. Nothing you can do, but you can learn how to be you in time. It's easy. Know that you can see isn't shown, that it isn't where you're meant to be. It's easy. All you need is to live like nowhere else, all in one place, so close. All you need is Ecuador. Ecuador is all you need.
So I hope you like it. And on how do I pick this topic and the things that I've done in my private practice is that the teachers that I had introduced me to this orthodontic world that I really love to work with. This is in Japan in 2013 with Dr. Junji Sugawara. I went there to his clinic, and back then he also worked with mini plates, skeletal anchorage, and OECD CTs. And that opened my mind because I live in a third world country and we have different possibilities here than in Japan. So I didn't know how I was going to do my work and to introduce this to my patients because we live in a different society. This is something that it was not that possible for us, and working with these kind of tools that maybe increase the cost of the orthodontics could be maybe difficult, but I believe it so much that I start working just like they teach me or they taught me, because they work with so much perfection and order that everything was like perfectly analyzed. So they had a photographic protocol for all the patients. They take photos every appointment, before the appointment, and they were always checking for a very good organized treatment plan. So I found this like very interesting. The treatments also were very fast. They finished their treatments in 10 months, even the surgical cases. So I found this very, very interesting because my orthodontics were plans that were lasting around a year and a half or 2 years. So This has been a very big transition for me, and we've been working this little by little, but we have a very, very, very good result. So also then, this is last year also, I went to Brazil, and I went to study with this doctor, that is Dr. Erte Silva, which I am very grateful also, because they introduced me to this 3D world that is not only about making like a show off of the 3D, but knowing exactly what you need to learn or what you can take advantage of the 3D. So we've been studying like around for a year now. This program is a year and a half, and we were supposed to end it last June, but we couldn't because of the COVID-19. So I think we're going to finish it next year. And every time I go to another country, I meet these very interesting people that have very good and new ideas of how we can manage our work. So I'm very blessed to have them, and I think that there is a before and after in my practice when I met them. So it was last year. I went to Japan in 2013, and since last year, I think I really have like an organized practice as I wanted. And one of the most important things is that we need to respect our work and respect our patients. One of the things that I appreciate a lot is about time. Once I hear this from, I don't know if you know her, but Oprah Winfrey, she had this podcast that is called Super Soul. And she invited very interesting people to talk about life. And when she started the program, she said this. And she said that one of the most valuable gifts you can give yourself is time. So time is a not removable asset that we have. So once we lost our time, we can never go back. So this is very interesting because I always believe that if we plan correctly our treatments, we could finish early and respect the time of our patients. We need a respect for our patients and also respect for our work, because we need to give time to our families, and we need our practice to be very profitable. I mean, it's going to be very useful, and we need to value our time, okay? So the time is very precious for us. So we need to preserve that. Sorry. Okay. Another concern that I have when I analyze my treatments, and this is a thing that put us a warning here that is always like bothering my mind. Why patients come for retreatments? The cases that I brought today, all of them are retreatments. Adult patients, not the kids, but adult patients come from 2 treatments, 3 treatments, 4 treatments. And what are we doing wrong that we are needing these retreatments? Why? So that's the question that I was always working on. And I've been trying to work with a lot of stability and what are the keys for stability. And we've been in this research because why patients come for retreatment, why everything fails in a matter of way that we can see. So I summar this that we need to respect we need a respect for nature, because nature is the most precious thing that we have. So nature is always changing. The bone is always changing. And we need to treat this like once we damage it, there's no going back. So we need to plan our treatments very, very well. So We cannot have these, our patients like having 2 treatments, 3 treatments. So the bone where we work is always remodeling. The bone is not as we were introduced in commercials. In TV commercials, like they always show the bone like something that breaks. If you if you do something to the bone, it will break. No, it's completely opposite. The bone is always changing. The cells are always working and remodeling the bone. So this is something we need to work with. We need to work together. Interdisciplinary treatments are the key to accomplish better results. This is something that I believe. I see that in our practice, is very organized because we prepare the patient at first with the periodontist, and the perio is always checking that everything is okay. We have this phase of hygiene phase that we always check the patient, and also with the prosthodontics. The prosthodontics are very important for us because they are going to show us their point of view. One thing that I also noticed is that in dentistry in general, the periodontics has one diagnosis, the rehab has other diagnosis, and we have other diagnoses. Even between different orthodontists, we can have different diagnoses. So why we cannot have one diagnosis for all of us? And what we've been doing in our clinic is working interdisciplinary to have one way to treat this patient. And once you find your workmates, your teammates, you need to be with them. I work with incredible prosthodontics and I wouldn't change them for anything. So that is very important. Also, another thing that we need to work with is the TMJ. The temporal mandibular joint is one of the most important things that we need to work with. So this relationship between the teeth and the TMJ is very intimate relation. So this condyle and the articular eminence must be together with the teeth. And the anterior guidance is a very important part of our treatment stability. And this is what the 3D bring to us. We can not only with the articulator or maybe clinical work, we can also with the 3D, we can see how is the TMJ inside the patient. Also with MRIs, MRIs here in Ecuador are very expensive, so we cannot do MRIs to all the patients, but we can do an exception if the patient needs it. So it is a very important tool also for our work. And this is what I was talking about. The 3D gives us a complete analysis of the craniofacial imaging. So we also we can do these articular cuts of the CBCT, and we can see how the TMJ is in relation here. So if we can have these images, we need to take advantage of them, and we need to take all the information that we could have from the CBCT. And also, if we have a lateral view or a sagittal view, the thing is that with the 3D, we can see both sides, not only the right one in the superimposition. So we can check the right side, the left side, and it would be very interesting to analyze both sides because of the asymmetries. That was something that we cannot check that much with the 2D imaging. So nowadays, we have this amazing tool that give us a lot of information. So we need to extract all that information for our patients. And something that is very important in our work is anchorage. The thing is that when we work without anchorage, I try to do it, and fortunately, when I study my degree, we always work with skeletal anchorage, and I learned to work with that since I study orthodontics. And I believe that we can manage and we can control secondary effects of the movements when we work with anchorage. And it is an important tool for work. We need to control and stabilize our treatments. So anchorage is an important key to our biomechanics. And what anchorage can we talk about? So this is the ones that I am working with. I use these mini screws. They are from Forestament. They are nighttime mini screws. They come in 3 presentations, like 8 millimeters, 10 millimeters, and 6 millimeters. And they have a bracket head where you can place wires and elastics and everything. I like them very much, and I use them in mostly all my treatments. I don't see my practice nowadays without anchorage, because the vertical control and the sagittal control and the 3D control is amazing. Also with the mini plates, nowadays I am trying to work with mini plates, and I am learning. This been like more than a year now that I've been working with them, and I found that the treatment times are very, very much decreasing, and it's more efficient. So this is like the most wonderful tool that I ever work with. It's very amazing. The treatments go very fast. And this is something that we need to work with, because the bone that it is remodeling always, constantly, and if we can place these mini screws or these mini plates to move the teeth, it's like we are in total control. So what's the most important and interesting thing about the bone? That we have different type of bones, like the type 1 and type 2 that have a very compact cortical, and it's a very hard bone, and it's not going to resorb that fast like the 3 and 4 type of bone that is going to have a very fast remodeling. For example, the mini screws of the buccal shelf and the infrazygomatic zone, they work very fine because the modeling of this bone that is very compact will give us more stability for the mini screws, and we can work with them for a long time. I don't have problem with the mini screws falling, and they are very stable in the bone. For example, when we do interradicular mini screws placing, sometimes, like in the study said, that the 40% of the mini screws are lost because of the remodeling of the bone, because the bone is very, we have a very trabecular zone in this area. So if we can choose an area to work with, we should work with compact bones. In these cases, like the palatal bone or infrazygomatic bone or buccal shelf bone, that is very, very, very compact bone, and it will be very great for working. For example, in these areas, also the mini plates are placed here, and the mini screws, I always love to work here in the infrazygomatic zone too, and in the buccal shelf that is between the 6 and the 7, the first molar and the second molar, in the buccal side of the mandibular area. They have type 1 or type 2, depending on the patient, and it's a very good bone to work with. Also, the palatal bone is very, very nice. In this anterior area, also, we have a compact bone to work with. Another thing that is very interesting for the stability of our treatments is the neutral zone. The neutral zone, as Dr. Peter Dawson described, is this area where everything is balanced. So the teeth are balanced by the tongue and the buccinator muscles in the cheek and the lips. So this neutral zone will stabilize our teeth. In that way, our treatment is going to be stable. So as Dr. Peter Dawson said, teeth will not stay stable where muscle does not want them to be. So if we have an open bite and the tongue is always in between, there is no stability. So we need to restore this neutral zone to have the stability of our treatments. So this is another key. So we have the 3D diagnosis, this neutral zone. For now, the anchorage and the material that we are working with. And we have another one that is the facial analysis of the patient and the occlusal analysis of the patient. So see in here that the neutral zone is very stable with lip competence. The lips are not forced for the closure and is a very relaxed face. Another key that we analyze when we are going to start a treatment is the teeth exposure with the relaxed lip, like you can see here in the second photograph. The lip exposure for people around 30s, 30 years, it must be like 2 millimeters or 3 millimeters on a woman. On a man could be like 2 millimeters. And as Dr. Kotlich said, the lip is going to fall down 1 millimeter every 10 years. So we need to have a very eye for doing this, because if we don't leave this exposure in, for example, in a 30-year-old patient, it's been that when she has 40, she's going to look very old, okay? So this exposure, again, for patients around 30s must be like 3 millimeters exposure to have a very nice aesthetics. And the smile is very important. Nowadays, I try to work most of my patients without extractions of the premolars. I like very much this kind of treatment where you can have a full mouth smile. So I like it very much. And also the proportion of the teeth are very important when we analyze a treatment plan, because it is the key of the stability of the face. So I'm going to show you that a little bit here when I start showing you the cases. And I want to show you this first case. This first case come to me like, what about like 4 years ago. And this patient, she's a doctor, a medical doctor, and this is her third treatment. I mean, she came with braces and she has 2 treatments before my treatment. And it's very sad for a patient that comes to you and said, it's been like 3 years with braces and I have no results. And she was desperate and she asked for help for us in the clinic. And what I want to show you is that, for example, when you see this X-ray, this is a 2D X-ray imaging. And what is important here is that we analyze this in 3D. Why? Well, if you see this first watch of this panoramic view, we can see that we don't have the right canine. The right canine is inside the palatal bone. And you can see in the right side also there's a mini screw and there are the braces on. we remove them for the treatment and we place our appliances. So this is what bothers me the most. When we see the CBCT, you can see how the roots are without support of bone. The roots are completely out of the alveolar bone. So this is very sad to see, because this was made by maybe an orthodontics that didn't check and didn't manage the biomechanics. So look at this lateral view. We can see this lateral here with the root completely out of the bone. So the patient had very good braces. She had a mini screw placed on here. If you can see, here is a mini screw. So she had a very expensive appliance in her mouth. What I want to say is that it's not the appliance, it's the biomechanics and it's the treatment plan. So we need to take care of that. So this is hair. And well, I leave you here my Instagram. If you want to give a feedback of the lecture, you're more than welcome to share your comments with me, and I will answer it to you if you want to share something, and if you like it, please share it. And going back to the case, look at the hair. So we have a canted plane here. So the occlusal plane is going down on the left side, and with more amount of gingival exposure on that side. And look at the missing canine. So she's been like all his treatment with that without that teeth. So it's not nice when she smiles and she have a missing tooth there. So she was very concerned because she didn't see any results, and she was very, very worried. So this is her third treatment. Okay, so if we see her and analyze her in the profile view, maybe she has a little bit of compressed muscles here in the menton area. But I will show you now the intraoral view so we can discuss a little bit further. And look at here. So here we have the mini screw. We have a periodontal problem here. Look the inflammation of the gum and the gingiva here. We have a crossbite in the back, in the right side. We have a crossbite of the molar. And also this is an extraction treatment. They did, I think, like 4 extractions, on her. And look at the inclination of the incisors. They are completely going backwards. And what we see in the CBCT, look at the roots of the lateral side here. You can touch it with your fingers if you go there, and it's very worrying because the support is very, very low. So we have also missing a second molar on the right side, the canine on the right side, and on the left, we have missing a premolar, and also extraction of 2 lower premolars, bicuspid. So we have a class 2 on the left side and a class 1, if we can say, in the right side. And also here in this area, in the right side, the first, second, and first molar, they have very low supports and resorption of the roots. So we cannot work that much with her. So we can see here what they were doing with the canine. The canine is here, we can see it, and it has a ligature here. So they were doing the movement from here in the palate to the mini screw. That was the biomechanics that they were using. So let's take a look on here. So when we look at the CBCT, what is worrying for us is the loss of bone that we have here on the right side. You can see the alveolar bone on the left side and compare it to the right side, and is very reabsorbed on that area. So what were they doing? I think the biomechanics that the last doctor was doing is that they were placing a power chain from the canine to the meniscus. So this force is also making a force through the buccal bone. That's why it is resorbed. And also the canine, when it was going to a backwards direction with the power chain, was moving the lateral to the front, to the buccal side, and that's when the roots went out. So that is not like the biomechanics, a good biomechanic for this case, because there was a lot of biological damage in here. The liberation of the canine for around 6 months, so she could rest, and periodontically she could rest also because she had a periodontal problem, so that needs to be treated. So we stabilize the patient periodontically, and I was working with the canine during this time without braces, only in the palatal side with the mini screw and the wire. And I also placed a veneer or a bridge on the canine so she can smile and have her tooth while I was working. So the wire that you see here is a TMA. I don't know if you have TMA back there, but I also know that maybe it could be a CNA. And this is like a 19 by 25 wire. And when the wire is activated, it's going backwards. So you can move the canine away from the lateral. Also, you could use a biomechanic from the buccal side if you want, but not with an elastic here, because elastic is doing a resorption with the buccal side. So maybe a cantilever, another wire that will, like a ballista. I don't know if you have listened ballista. You can move the canine away and then place it. And I leave that mini screw, but I didn't use it. I only used my buccal side mini screw. So I found this very interesting because you can do biomechanics and also help the patient and have very good results. So look at what's on here, what I was saying, that the roots of the premolars and the molar are very small. We have also a loss of bone here. And what I did is that when I work with the braces, I put a fixed retention here, a fixed retention wire here. So I maintain those teeth attached, so I don't apply that much force on them. And also a very good thing that I can work with, that I like a lot, is that I can work with 2 wires, double wires in here. And another thing that you can see here in the x-ray that is very interesting is that when they were doing the liberation of this canine, because when she came here, she already had the bracket placed on the canine, is that the canine was cut in half. So you can see here that the crown is half of the crown. So I don't know if when they were removing the bone, they cut the crown, and you can see here, look at this buccal side view of the patient. So the crown is half of the crown. And now we need to work with the prosthetic dentistry. So I work with Dr. Vifalquez, that is my prosto, and he will do veneers on that teeth. So I work with my brackets once I have the canine down, and I start doing the sequence that I always do in the maxillar. I use upper night ties, 12, 16 by 22, and 19 by 25. And for a working wire, when we have to do retractions or use ligatures, I use stainless steel 19 by 25. And in the mandibular bone, in the mandibular teeth, I use upper night ties. Why? Because then the mandibular bone is more cortical and the maxillar is more tuberculous. So in the mandibular bone that is very hard, we need to coordinate both arches. So the mandibular bone will work better with upper night ties when we work with self-ligation brackets. So this is the sequence that I use always, or most of the time. So I use in the mandibular bone an upper night tie 12, 16 by 16, and 19 by, and the other was well placed, and it was going in direction to the facial asymmetry. So we do our tracings. The 3D tracings, the interesting thing about the 3D tracings is that, for example, if you place the A point, it's going to be a 3D A point. No, it's not only a sagittal view A point. So this I'm going to explain a little bit further in other clinical case, and you can see it that that the study of the 3D is a 3D cephalometric also. So this is an open view, so you can see this lateral asymmetry to the left side. We can see it much better here with good bone support that we can work. And this is hair. This is also a retreatment. And the thing that she didn't like is that she showed too much this lower tooth area, this teeth area. So it made her notice a lot of more her problem. So she didn't want surgery, and she didn't like this crossbite here. She had a very good lip competence, very nice teeth, but this is also like bothering me. I don't like it, so we are going to correct that. And look at the upper lip. The upper lip is way backwards in comparison to the lower third. So we need to do a little bit of projection of that upper lip to make her better. So look at the intraoral photographs. So we can see here, the midline deviation to the left side with a crossbite, anterior crossbite in this side, and a poor overbite on the other side. So we don't have a transversal problem, and the asymmetry is going to the left. So she's going to miss this molar. So we can take advantage of that and move backwards, do a distalization of this class 3, so we can compensate the asymmetry. And one of the things that I like to work with is with Woofer braces. I love these braces. I use on her these braces, but in the aesthetics ones. And you can see that this is perfectly fabric. This is perfect. It's a very good material. They are from Forest Talent, and they are Germany, from Germany. Everything you see here is not from Ecuador, only the patients and me. And so, okay, I place a mini screw here after the extraction, like around 3 months after the extraction, and I start doing the distalization of this side. And I place here a mini screw and a power arm to be at the center of the resistance so we can do a pure distalization movement. So you can see here the braces on and the movement. So this is very nice. And what happened here is that I use as a working wire, and this is a mistake that I made, is that this was not a full size wire. I think this was like a 17 by 25. It was not 19 by 25. And what I saw is that the teeth were moving, like doing a tipping, and they were not moving straight. So I need to go back and stabilize that with a full size wire. And once they were straight, then do again the other movement. And also I was trying to correct here the crossbite. And as I was saying to you, she is an Instagram influencer, and she worked as taking picture on herself, etc. So she asked me to remove the upper braces, and I was not that convinced, but I did it because of her, because she needed to have their braces off. And what I did is that once that I had this side in a class 1, I tried to overcorrect a little bit, and I placed an Essex here. Do you know Essex from the Spline? This is 060 retainer could be, and a removable retainer, and I cut here, and I did a button to use a class 3 elastics. So you can see now that the implant is placed, and this is how the treatment ends. Now we have a bilateral class 1 with a good overbite with the midline center. And look here, I think this is a very nice result. Here's the temporary crown. And this is how they look in the occlusal view. They are very, very nice. And this is something I like a lot. You can look at here how the upper lip is much better. The upper lip have a lot of more support. And look at here. The main concern of her was accomplished. We did here, we correct here the crossbite, and now when she smiles, she doesn't show that lower teeth anymore. So this is what she liked. So she still have hair asymmetry because we didn't do surgery on her, but is very beautiful also. So you can see the before and after. She's also having her a little bit of deviation of the menton, but is very nice finishing. So you can see the lower lip in contour of the upper lip and have a very good, nice support. You can see here the smile. So here, when you see the smile, you cannot see the lower teeth. She was very, very happy. So this is an important way to analyze the cases with the CBCT, because we are aware of that she has an asymmetry that we are the 3D. And look at here, this one she's not having buttocks or fillings in there. So it's only orthodontic. So that's very nice for her because it's a very much improved and nicer profile. So these pictures are very important because I do the pictures myself. We don't have a photographer in our clinic. The photographs, I do my photographs, and for the patient and for diagnosis and for publishing and for documentation, it's a very important way that we can preserve our work. So if you want to know a little bit of intraoral photography, we can talk about after the lecture. If you have any questions on the photographs, I use a professional camera and a macro 100 lens. So I've been into photographs since I was graduate. I have a photograph course here in my country with a friend of mine that he's from Venezuela, and he give pictures and these photographs courses all around the world. So if you're interested, you can also write me if you have any question. And now we can see other case. So this is another retreatment. She's a 27-year-old, and I am very concerned of this because I think like the 90% of the patients, adult patients, they need retreatment. There are only a few of them that they don't need retreatment. And what I ask again, what are we doing wrong that we have like 3 retreatments or something like that? It's not, that is very worrying for me. So what she said is, I don't like my profile, my teeth are crowded, and I feel that something is wrong with my bite. So she wanted to correct her profile, and I'm going to show you how is she. Well, this is a photographic protocol that I like a lot, and we took pictures in every angle of the patient. And what she didn't like of her profile was her lower lip and the menton. So we can clearly see in this view that there's a deficit in here, and also she's a class 2 patient, obviously, and this is the thing that we need to correct. So I like this very much. This I started, this is a very short treatment. I haven't seen her now for around 4 months of the, okay, so I start working on April after the COVID, and we've been seeing a few patients. So maybe we lost like 3 months that we didn't see patients like we were used to before. So we start working like a 30% of the clinic, 3% of the patient, and now we can look more patients. She is still in treatment, but the treatment of her was very, very quickly. We managed her treatment with mini plates, and I'm going to show you how we do the diagnosis. This diagnosis is made in Brazil by EC3D. It's called the software, and this software plan the 3D analysis, like I was saying. So you can see here also her smile. The deficit of the menton is very, we can notice here. So this is what we are going to try to correct. And I'm going to show you what was the treatment plan for her. Okay, so let's see. This is the lateral view of her teeth. On the right side, we have a class 2 patient with an anterior, a very deficit of the anterior guidance, a very poor anterior guidance. This could be considered mostly like an open bite because the laterals are like border to border. So what else? You can see on the left side, a class 3 patient. So we can think about a little bit of symmetry here, because it's not like a class 2 division 1 patient. It's like a class 2 and class 3 patient with a pro-inclination of the incisors. Now, in the front view, you can see the deviation of the midline to the left side. So we had a little bit of crowding here, a little bit of retractions, and you can see that the teeth are have the prescription of like to inside, like the torque of the molars. So you can see here a little bit of crowding and not that much problem in the occlusal view. The most problem is in the sagittal, in the vertical problem. So what we can see here is that the best occlusions are not functioning. So all the back teeth are touching itself. So you can see here, sorry, that we have here the premature contact points in the back. So we are going to look at the 3D. So this is the software that we use in Brazil to analyze the patients. So you can see here the craniofacial points here, and you can see the asymmetries. In this case, we can see that maybe the asymmetry is only dental because it's not, there's no deviation of the mental. And in this lateral view, we can see the class 2. So this is important in the craniofacial point of view. So once we're going to do the 3D study, we need to take the pictures of the patients. The pictures are very important because the pictures are the ones that are going to guide the CBCT where it's going to be placed. So the picture must be taken with a natural posture of the head. So it's very important to send the EC3D or your tomography center with a correct photograph protocol so they can arrange the face with the tomography, with the CBCT, okay? So it's very important that we check that when we take the pictures and we send them. So this is her, and we can analyze her face, look at her smile, and look at the midline. She's a very symmetrical patient on this front point of view. And we can see at this first way of looking her that the midline deviation of the lower teeth is a dental problem, not a skeletal problem. So here we can see in comparison with the CBCT, the menton that is, the chin is very backwards. So this is obviously this is a class 2 patient. And the lip exposure. Remember when I was saying in the other case about the lip exposure, she only shows 1 millimeter, and the mandible we can see 2 millimeters. So this is the first way that we are going to analyze her because we need to make that teeth exposure. We need that to make her younger. So look at her smile. She has a very nice smile. Her smile contour is very nice, so we can manage that. What she doesn't like, remember, is her profile, but the smile is very, very nice. And one thing that we have to look at in the CBCT is the TMJ, as we were saying. So look at the left TMJ and look at the right one. So the right one have the condyle in the articular eminence very well placed. So look at the left one. We can see that here the TMJ and the condyle is going down. So what we can thing here is that she has a fulcrum that is moving the condyle down. Okay, so that is what we need to arrange when we do our treatment plan, that the condyle goes to the eminence. Okay, so she has a click on the right side, and we corroborate this with the MRI. In the MRI, we can see the right side when you can see here the displacement of the disc with reduction. So it goes with reductions to the back side. So it's not that bad. Well, we can work with that. And in the left side, we have the disc placed in closure and with open bite. So we can also have this coronal view of the patient, and we can see that here on the right side, we also have a mid displacement to medial displacement of the disc, and the other is perfect. So this CBCT, to analyze this TMJ, must be taken in maximum intercuspation. So this is how we see that the CBCT was taken with maximum intercuspation, because that is the only way that we could analyze the TMJ. So look at the lateral view of the CBCT. We can see here a 12 millimeter menton point to back. And this is from Andrews, and we have a 3.5 millimeters protrusion of the incisor. So we should move backwards these and distalize these incisors, like to have them in 1 millimeter from the Andrews line. What's the interesting here, and this is what I want you to see in the CBCTs, in the 3D, is that we can analyze one side in comparison to the other side. So we were talking about an asymmetry, and you can also see that if we measure the ramus and the body of the mandible, we have difference between both sides. So we have an internal asymmetry that we cannot see because it is like camouflage and compensated with other structures. So the difference between one side and other side is 5 millimeters. So when we talk about 5 millimeters, we should think that it's a very asymmetrical patient, but it's not, because it's compensated with other craniofacial structures. Also here, you can see that in the coronal view, the left side is going a little bit forward, okay? Also here, this is again the view of the TMJ. You can see here that the left side has a fulcrum. And if you see the coronal view here, there's a lateral movement to lateral of the right condyle. So we need to do this so we can place the condyles in the eminence. Okay, so we can sterilize our treatment. Also, a very good thing that we can analyze is the symmetry of the maxilla and the mandible. So it's very symmetrical in both sides, in the upper jaw and in the lower jaw. And these triangles also, you can see the linear difference between the point A and the point B. So what we were talking about when we do 3D cephalometrics is that we take not the lateral view of the point A, but the center of the point A, also with the point B. And that measurement talks us about a 6.4 millimeter discrepancy. That's a class 2 patient. Also, we can see not only the relation between the upper incisor with the lower incisor from one side, as we did in 2D, in 3D, we can see both sides, the right side and the left side. So in this view, we can corroborate the protrusion of the teeth. So in our treatment plan, we are going to move backwards, okay, to distalize. Also, there's no transversal problem here, but it's a very important way to see it. And the airway. Okay, and this is a panoramic view also. You can see it here. You can see the overbite and the overjet that are very poor, like a 0.7 overbite. So that is like an open bite. That's why she had these contact points on the back. So this is a summary. So you can see here, we need to stabilize the TMJ, and also we need to improve the protrusion of the teeth, and how we're going to correct the class 2. So this is the summary of the planning from this patient. And what we did is that we placed 4 mini plates between the first and the second molar to do 3D movements. So we are going to manage the sagittal, transversal, and vertical problems of the patient. So also we're going to do a little bit of a corticotomy on the back side of the second lower molars to have a faster movement there. And this is how we plan it. In the class 2, what are we going to do is that we're going to arrange her lower lip. So she only will do a mentoplasty. So she's only going to work in the chin. So it's not going to do a sagittal surgery of the mandible. And what about the arc wires? The mini plates are going to do a lot of expansion when we move the teeth. So in this case, in comparison to the self-ligating braces, we are going to use lower nitals because we need to compensate the expansion. So this is like something that we need to think about, and we're going to work with lower nitals. And then when we work with the stainless steels, or when we are not using the mini plates, we can also coordinate the arches. So this is the progress of the case, and you can see how the lower lip is going have a very nice curvature here. It's a very nice improvement for her. And look at her smile. Well, her smile was very beautiful at the beginning because she's very, very nice. But what I want you to see is look at the masseter muscle. The masseter muscle at the beginning of the treatment was very contracted. And look how the face now is very, 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 very thin. That is because we don't have any more that contact points up on the back. So this is, I found this very interesting because this is like a 6-month change. It's not like a year or a year and a half, it's 6 months. So we can see an improvement on her face with very relaxed masseter muscles. I like it very much. You can see it here also. So this is the beginning of the treatment. And this is how we did the biomechanics with the mini plates. And I used sliding jigs. She had an internal asymmetry and we need to compensate that. So we didn't do vertical control on the right lower side, but we have vertical control on the other 3 sides. So we do the retraction on both sides, and we are controlling in 3D the patient in every way. So what's happening here? When you do this kind of work, what could happen is that you can have a little bit of an open bite and then it will close. So I wanted to show a little bit of how I do the slidings. This is what I was saying, that I have these videos in Spanish, but when you can do, let me go a little bit forward here so you can see. You do the omega, and you don't need to remove the wire to place the slidings. In the video, I'm doing the sliding with a stainless steel 19 by 25, but you can do it with a round wire. That could be like a 606 wire, stainless steel. So you place the loop and then you measure the height where you want, and that doesn't interfere with the hooks of the braces. And then you're going to turn forward and then you place it. Okay, the interesting part comes here when you are going to do the hook, because how you do the hook is important. So you are not, the thing here is that you can place the sliding without taking the wire out, the main wire. So now you go down again and look how it goes.
Para enganchar el cursor del otro extremo, y vamos a regresar.
So you can see how it goes. You can see it there.
Y ahí es donde vamos a hacer
and then you do the hook.
Del tornillo.
So this is a stainless steel 19 by 25, so you can do it with a round wire without problems. With the mini plates, I use Ricketts prescription that is a slot 18. It's not a slot 22. It's a slot 18. You can see the hook there. And then you cut it, and look how I place it. You go from down, and then you going up, and then you can place it without taking out the wire. Okay, so that's it. I hope you found that useful. Also, you can work with power arms, pretty power hooks to the mini plates or the mini screws. This could be used with mini screws. The main difference is that we are going to last a lot of time, more time, because this is a 6-month, 7-month treatment. And with the mini screw, you cannot control that much in the vertical dimension. So sometimes when I use this kind of treatments with mini screws is that I need to work the sagittal part first and then the vertical part. So it's kind of in 2 ways. So this you do the treatment in one time. So look at the overbite, how is much better. The overbite is very nice. And this is, as I was saying, this is a 7-month treatment. I couldn't have the result if I would not work with the mini plates. The mini plates are the one that allows me to do this kind of work without extractions and without IPR, because sometimes with the mini screws is not enough. And the contact points are very important part of the occlusion. That's why we need to try not to do IPR. So look at the lower lip again, it's very nice. And this is what I was saying, this when I was start working with the round wires, this is what happened, an open bites occur. So we need to close the bite again with the treatment. So this is the end. Now I'm detailing because this is a Ricketts prescription. So I'm now doing the final details before I remove the braces, but this is a 7-month treatment. So let's see, I have two more cases. I think we have enough time, yes. And look at this. In the 3D, we can analyze the patients in all the perspectives. So we can see in the back, in the front, and just only watching this craniofacial view, we can see that she is a class 1 patient with a lot of protrusion, So there is no skeletal problem, just a dental problem, and we can manage this with modern biomechanics. So look at here, you can see the incisors protrusion. This is one of my favorite ever cases because of the biomechanics and the treatment and the appliances. So look at here. She's a 40-year-old patient. This is her 4th treatment. And she doesn't came to me. She went to the prosthodontics because she wanted to do veneers on her teeth. When the prosto saw her, he said to her, if I do veneers in you, you will have to ruin your teeth, and we need to make your teeth very, very small. So it's not an option for us, and you need to do orthodontics. And she said, like, no, it's I had 3 failed treatments and I don't want to do it anymore. So she's a 40-year-old patient, and look at her. She wanted to do veneers, but if she do veneers, she need to ruin all her teeth, because it would be a not conservative treatment. So what we tried to do with her was to convince her to do orthodontics. The only way that she would do orthodontics if she do invisible orthodontics. So look at her lips and the menton. She cannot close her lips. She have these muscles very tight, so we don't have a lip competence here. And look at the protrusion of the incisors. The incisors are very protrude, and we need to correct that. And that is the main concern of her. She doesn't like her incisors because she feels that they are very protrude, which they are. So let's see. She needs to place an implant on the right side, and she's a patient of 3 orthodontics before us, so we need to think this very, very much. Now she has 2 years of removing her braces, and she's very stable. And I think we made the correct choice for her. So what are our choices for this protrusion? Maybe extract premolars or do IPR. But in the way that I am working right now, I'm trying to avoid extractions. And the thing that I was studying these days was a lot of Christian's work, and he showed a lot of mini screws treatments without extractions. So we did a proposal for her, and she didn't have a lot of crowding. The crowding was not the problem was the protrusion. So we need a space to correct that protrusion, and we are going to obtain it. So Dr. Sanjay was talking about lingual orthodontics. I love lingual orthodontics. I'm not doing that much as I did before right now, because I cannot manage lingual orthodontics with the mini plates, but I feel very passionate about this kind of treatments because they are invisible orthodontics for adult patients, and it's a very good alternative, even for this kind of patients that are tired of orthodontics because they have 2 treatments or 3 treatments before. So these braces are 18 slot 2D. Why they are 2D? Because they don't have torque information on them. we can only work in sagittal and vertical. We don't have torque on them. So let's see. What's the wire sequence that I use in lingual orthodontics with these braces? I'm sorry. In the maxilla, I use an upper nitide 12, a 16, and a 16 by 16. And in the lower, I will use the same. And here, yes, I do work with lower nitides. The thing is that here, I coordinate the arc wires because I bend all of them. So this is easier for me because I managed the transversal point of view of the arches. And the working wires would be a stainless steel 16, but Australian. I don't know if you've seen Australian wires. They are much more thicker. So this is what I did with her. This is a case that I like very much. I like a lot of my cases, but this is one of my favorites. And what I did is that I placed 2 mini screws on the palatal side. These mini screws are 10 millimeter mini screws, bracket head, ortho-easy from Prosthetic Dent. And I placed them between second premolar and the first premolar. So I placed a stainless steel wire here, a stainless steel wire with an open coil. So the open coil is activated in the way that this will distalize the molars. So you can see here, you can see this portion of wire that is going in front of the mini screw. This is because this was debonded by accident. So this side does not distalize because it was debonded. But look at the other side. Look the amount of wire that you have remained in here, and look the amount of distillation that we have. So this is what happened. The wire and the open coil work in a way that the molar is going to distalize, and the wire is going shorter because it's the amount of distalization that you have. And then if you want more distalization, you will change the wire. Okay, so this is how I manage the upper maxilla, the maxilla. And in the lower jaw, what I use is that I use a buccal shelf mini screw. This is an 8 millimeter mini screw attached to buccal braces in here because I cannot put no anchorage on this lingual side. So this was the only alternative. And in the other side, you can see that we don't have molars. So I place in the alveolar bone a 6 millimeter mini screw to make the distalization. The distalization is the most biological movement for the teeth. We have a lot of problems when we measurize. It takes a long, long time. I think it takes longer than distalizing, okay? So I prefer always to distalize with vertical control so we can have our T&J in health. So for the buccal shelf mini screw, I like to drill, even though the literature said that it doesn't make a difference. But I like to drill the mini screws of the buccal shelf because it's easier for me when I start placing them and not splitting the mini screw, because sometimes it's very, if you have an entrance, it's more easy to place. So I like to make an entrance with a drill and then going in. So look at the distalization here. It's going very, very nice. We are distalizing here and we have a lot of space in the back. So look at the wires, and at the same time that we are making the distalization, we are doing the anterior retraction. I don't know if you can see here, but I have the power chains. They are clear. That's why maybe you cannot see them, but they are in there. and we are making the distalization. If you see, this is the Australian stainless steel. It's like a little bit dark color. It's not gray like the other wires. And it's a very nice wire to bend. When we have to bend a lot in Lingual Orthodontics, so the bending is much easier with this kind of wire. I like it very much. So once we are doing the retraction, we are also working with elastics and intermaxillary elastics. So I'm going to show you in the next picture. And in the mandible, we are still working with 2 power chains at a time, and we are doing the distalization, okay? So this is going very good. And you can also see here the mini screw. Once we finish the retraction, we can also place a wire here for anchorage. And we can also do more retraction without losing anchorage. So let's see here, the Canine has a little button here, an aesthetic button that I made for aesthetics because she has a lingual orthodontics, so it has to be a very aesthetic orthodontics. And she have in the premolar a bracket that is a sapphire bracket, and we are using an elastic, a clear latex-free elastics, because it also needs to be very aesthetic. So this is 1/8 medium. This will help to preserve the class 1. If you can see, the retraction of the mandible is going faster than the upper jaw, okay? Because in the maxilla, I did the molar distalization, and then I am moving the incisors, but in the lower, it's going much easier. So let's see. We were talking about the TMJ, and we cannot do distalization movements without vertical control. So what I did here is that I used the same mini screws that I use for the distalization for the vertical control. So one of the vertical control is placing, you can achieve it placing rod buccal tubes that will have rod prescription, and the rod prescription will, with a rectangular wire, will help controlling the lingual cuspid, the palatal cuspid of the second molar, that is the hardest one to control. So here we are going to use elastic from the buccal, from the palatal cusp to a wire. So this wire is a 19/25 stainless steel, and I did an omega here, so I can do the intrusion of the molars and have vertical control for the back of the teeth, okay? So once we were doing our treatment, you can see here that we are also doing retraction. Look at here how we anchorage the molars. This is not activated anymore, and how we can do the retractions. When I check the centric occlusion, the patient still have premature contact points in the back. So we cannot end the treatment with premature contact points in the back. So I place again to do more intrusion of the serines, of the second molars. So we have a very good vertical control in the back, so we can manage the occlusion instability with the TMJ. So this is the article that I read when I decided to do this treatment. And it's an article of Chris Chang if you want to check it. And this is why I wanted to do it, because if this was my mouth, I wouldn't like to have extractions on me, and neither IPR. So, and so I think I found this very, very practical. So this was an idea to apply it to lingual orthodontics. So the vertical control here is very important because we need to place implants also. So we are going to do a little bit of intrusion on the buccal side so we can have enough space for the lower crowns. And look at here, this is the initial treatment, the first pictures. I'm sorry. So you can see the protrusion of the upper incisors. It's very, very, very protrude. So I'm going to show you the comparison of the retraction. You can see the emergency profile of the incisors that is very nice, and the teeth look very straight. And this is the before and after. She still have appliances in the after. In this after picture, you can see a little bit of here of a bracket here. So, but the change is very nice. Is very nice, and the patient is very thankful for the treatment that she had, because her teeth are preserved for the respect of the nature that we have, and she's not doing veneers anymore, and is a very conservative treatment. So in adult patients, doing extraction, losing support of the soft tissue, for me is not an option. And the importance of the contact of the first premolar with the lowers contact is very important. Dr. Sato in the Mew technique talks a lot about that. The first premolar is a very, very important tooth for the occlusion. So another thing that impressed me and that keeps me motivated by doing this kind of treatments is, you can see the muscles, the mental muscle. You can see now a relaxation of the muscles, and the lip closure is very much nicer. And look at the profile of the lips is a very huge change for her. So she's very beautiful. So you can see here we did a little bit of remodeling of these two incisors, and because they were like rounded incisors, so we made them a little bit square incisors, but it was a little bit, not that much. So she didn't want to do any more, nothing in her laterals. Something I would suggest, maybe this incisor edge, maybe make it more square, but she was very happy with the results, and she didn't need nothing else. So the money that she spent is a lot less money than if she would did veneers with a biological cost that we were not allowed to make it. So look at her. This is her smile. She had a very nice smile. And look at the profile. The teeth in the front view are very, 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 very nice with no extractions. And this 3/4 picture is also very nice. So you can see how she goes. And look at the occlusion, a class 1 occlusion, very nice. Do you remember the first pictures when she was using the intermaxillary elastics? She had a very big overjet, and look at now, it's very nice. So this is when we remove the appliances. She have here also the mini screw scar, but it's going to be well in a little while. So we did fixed retentions on her and look at the anterior guidance. That is a very big important part in our treatment. It's very nice. And I want to share with you the superimposition of the pre-treatment and the post-treatment. You can see the mini screws are placing here. I remember that I told you that I need another mini screw in the upper, in the maxilla for more intrusion. So you can see here, this is the pre-treatment, the post-treatment, I mean, and we are going to do the superimposition. I want you to look at this. The superimposition is very impressive because we have an amount of distalization, a very important amount of distalization, you can see. So let's wait. So look at the roots are very straight. They are very nice, well placed. Okay, so here we go. Look at the white teeth and the clear one. And now you will see how the teeth go backwards in the pre-treatment with the superimposition of the 3D. You can see here the amount of distalization that we have. It's a very nice result. So this is the end. This is a control. And the most important thing is then that when we did the final computed tomography, we can see that the condyles are very well placed in the articular eminence. So this is the sign that we can be released of any future problem of the TMJ. So you can see here, this is 1 year after treatment. She doesn't have a retainer, a fixed retainer in the maxilla anymore. And I have another case, I think we have time. Yes, so I'm going to show you another case. This is also a mini plate case. And she's a dentist and she's a pediatric dentist here in Ecuador. So I know her because I was her teacher when she was studying dentistry. So now she came to me and this is her third treatment. So it's very concerned for me so that's why I mention it very much, because 3 treatments in a life of 30 years is a lot, or 40 years, it's a lot. So that is why I said that one of the most valuable things that we have is time. So we cannot play with time. And we have to change our sales mentality to a service mentality. We are not selling aligners. We are not selling this kind of stuff. We are serving our patients for a good treatment, for a stable treatment. I never imagined that I live, as I said, I live in a third world country and we can make this happen. Work with 3D, with skeletal anchorage, with very good kind of material because we believe in it. I believe in the treatments that I do. That's why the patients allow to do this, because it's an inversion. They are paying for this, but we have to change our mind to a service mentality, okay? So she wants a retreatment without extractions and IPR. So what can we do for her? Her teeth were very small. we cannot do IPR because we're very, very, very small and very sensitive. And I am not doing IPR anymore. I like to preserve the teeth and the tissue of the teeth because I believe in nature. And extractions, we have tools now for not doing extractions. And we did the study on hair. So this is hair. With the natural posture of the head, we do the superimposition of the initial picture with the computed tomography. And we can see that she's a class 1 patient, a little bit of a class 2 tendency, but she mostly is a class 1 patient. And the upper incisors are backwards. Also, you can see that she has a little bit of an open bite. I will show you. So the airway is very good. We also always analyze the airway. A lot of patients nowadays come with apnea. So now we try to care a lot about that. So look at the anterior guidance, and she had like, here you can see like a 2 millimeter anterior guidance. And let me go back, I'm sorry. Okay, so you can see that the incisors are a little bit back, the upper ones, and the lower ones too, but she had a lot of crowding. I'm going to show you. So here's a little bit of an asymmetry, and the left side is a little bit in front in comparison of the left side, and that will reflect on the menton, you will see. So the left side is also a fulcrum here. You can see a fulcrum. The condyle is a little bit down, and the right one is well placed. You can see this rotation of the condyle. So we need to place that condyle in the articular eminence for a good treatment. Also, the left condyle is moving lateral. You can see here. You can see a space here, and this condyle is moved lateral. And down, you can see here how, in comparison to the right side, the left one has a fulcrum in here. Okay, so what's the treatment plan? We are going to place on here 4 mini plates, and we are going to work with vertical control and a distalization because we need to close the open bite. So this is hair, and you can see the lateral deviation of the menton here. So she needs to, we're going to work with that thing. So look at her smile. She had very small laterals, and the proportion when she smiled is not that correct. So we are going to make that happen on her and make them beautiful. So she has a very nice lips. I'm sorry. And look at her profile. The teeth are very straight. But look what happened here. In the moment we place brackets here, it's going to produce an open bite. So the upper side, microphone open.
கீரை சூப்பர். ஏன் நீ எல்லாரும் குடிக்கும் போது குடிக்க மாட்ற? ஏன்னா எனக்கு தெரிய மாட்டேங்குது. ஏமா டேய்.
Silent that microphone. Sorry. Okay, thank you. Okay, so going back. So we need a space here. Imagine that this lateral is a 7 or 8 millimeter lateral. So this is right now like a 5 millimeter. So we need a lot of space for this lateral. These laterals are so small that here, that when you see it, they already have composite. They are smaller than you can see. So the amount of crowding is much higher than you see here because we need a space for these laterals to make them bigger. So the moment we place brackets here in this crowding, what we are going to have is an open bite, because they are going to align this way, and then you will have this. So what are we going to do? Because we are not doing extraction and we are not doing IPR. So we are going to do a distalization movement. Remember that I said that the distalization is the most biological movement that we can do. And we will have a vertical control in a way that she has their TMJ stable and an anterior guidance very well placed. So look at this picture, you can see the incisors that are very retro and clean. So once we place the braces, they are going to go to the front. This is very interesting, but this is because this is how biomechanics works. And this is, we have to start thinking what we want to achieve what we want. So she also have a very small premolars. We did not make these premolars bigger. We leave them that way. And you can see the amount of composite that she have is a very big amount of composite on the 4 frontal incisors. Also, another thing that we can do with the 3D is that we can obtain the patient models we can do the mini plate surgery, and we can do the mini plates bending outside the mouth of the patient, and that will make the surgery much faster and more comfortable for the patient. So this is what happened, and this is what I was predicting. Once the case is aligning, in that moment we have an open bite in here. So you can see that it's aligning, but at the same time we are doing the retrusion. This is very different from other treatments, because we are aligning at the same time we are doing the retraction. We are not doing aligning and leveling, then the retraction, and then the finalization. We are doing all at the same time. We are doing the intrusion, the stabilization, and the alignment at the same time that we are starting the treatment. That's why it's so quickly. And you see that the bite is opening. So the wire sequence that I use with her is the same that I use with the other mini plate patient, the first one. So could be lower nitides in the maxilla and mandible. Because why lower? Because the mini plates are going to overexpand our patient, and we need to control transversal. So the mini plates, when you place them, there are a lot of cells working to repair it. That's why when you place mini plates, the first 4 months you can work, and they are going to work very quickly because of the wrap, because of the acceleration process that begin happening in here. So this is what we've done. We start doing distalization with vertical control in one time. Now you can see that the incisors don't have a space right now. And you can see how the bite is opening as we predict in the beginning. If we would not have the mini plates, we could not have corrected this. So this is very important us to watch. This is the frontal view. You can see here how small the laterals are and how they are full of composite. Once we open, we maintain the space with a closed coil. This was the beginning. Let me show you. I start opening the distal side, but then the rehab asked me to open the mesial side because she wanted to grow a little bit on the central incisors also. So we start working that way. You can look here, look at the anterior guidance here is very well done. And we are working here also with intermaxillary elastics. So in the back, we are also working the vertical control. This is what I was saying. She's going to change this angle. So she asked me to open the space also in mesially and distally for the lateral incisors. And this is how she finished her treatment. And you can see that this is a very stable treatment. This is a 8-month treatment. And this 8-month treatment is with the composites included. So this is a very conservative way because one, she's doing a retreatment. So we cannot afford another failure. And working a conservative way with composite is a very conservative way to work because we're only do incisal edges and it's not that much. So this is a very conservative way to work because we're not our treatment, which is very important for the long-term stability. So you can see here that the bipupillar plane is parallel to the occlusal plane, and it's very nice. I think my internet is going a little bit down. I hope you don't miss anything. So look at her. This is her final smile. She's very, 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 very nice. A full smile like we want. And the doctor is the Dr. Bruno, and he works in Essentia, Odontología, if you want to follow them. He did the composites. It's a very nice conservative work. And you can see that they look very natural. And we did an orthodontic treatment in a short time with vertical control, with distalization movement, with a 3D diagnosis. And look at here how the anterior guidance is very well placed. This will give us a lot of stability. So you can see here how she ends. Look at the occlusion, it's very nice. The occlusion is very, very well done. So this is the before. So let's remember. You can see how this crowding will cause an open bite if we would not have the space. And this is how she finished. And this is the lateral occlusion, nice occlusion. And one thing that I want to show you before we finish is that this is an occlusion checking that I use with my patient. This is a shim stock of 12 microns, and I use them to see that the patient have simultaneous contact points in the back and a soft anterior guidance. So how can we check that? We place the shim stock paper on the back, and we can see that the patient bites on every teeth. So that's why we see the stabilization of the bite. And in the anterior zone, the shim stock foil is going to go out without problem, without interference, because the anterior guidance have to be soft, okay? And when we do this checking, we also use acute film for contact points, and it will show us the true contact points, because there are very thick papers that is going to mark everywhere. So it's not going to be that useful for us. So I want to show you this. I'm talking here in Spanish, sorry.
Este fue un caso que manejamos con 4 mini placas,
un tratamiento de
ortodoncia súper conservador.
Is to listen when I check the contacts. And you can listen how she bites. What I'm saying is that I didn't do structures or IPR, and we managed the case with 4 mini plates.
Con pandemia incluida. Entonces, resolvimos el apiñamiento inferior y agrandamos el espacio para los laterales que estaban chiquititos. Esto se resolvió con resinas y la estabilidad del caso. Miren la estabilidad oclusal del tratamiento.
Did you
Y miren
listen?
cuando chequeamos la
That's very
oclusión,
important. So then we check the occlusion
tenemos contactos simultáneos. Aquí
and
está
has
flojita la vía anterior como
simultaneous
debe ser.
contact points and a soft
Abrimos,
anterior
cierra,
guidance.
abre, muerde, ahí. Muerdemos, abrimos grande.
And you can
Cerramos.
see that the paper,
Ahí está, con contactos simultáneos.
and you can listen how she bites. So this is the final picture of the exposure of the incisors, which is very nice. And you can see how this doesn't look like composites. And look at her with a very nice, stable smile. So you can follow them. And also if you want, as I said, if you want to share something about here, I can share with you. So talking a little bit about the conclusion, orthodontics should be considered the first alternative of a complete oral rehabilitation. So we need to work interdisciplinary, and if we must teach our patients and our dentist co-workers that the first conservative alternative must be orthodontics, then the rehab, because we are moving the whole maxilla, we are moving the teeth, we are moving everything in a conservative way. 3D diagnosis open new ways to analyze our patients individually. What happened with the old cephalometrics that were a lot of measures that were not able to use because because we're taken with other patients that are not the same as ours. So we need to analyze the patient individually. With 3D diagnosis, we analyze the patient as an individual, not in comparison with other cephalometric standards. So with modern biomechanics, we can reduce premolar extractions and also IPR, and we need to preserve the TMJ's health as a priority. So this is my conclusion. And to make another closure, this is when I went to Agra last year, which I loved, the Taj Mahal. And I think this worked for me, this whole treatment thing, because I changed the way I look at my patients. So this is a quote from Dr. Weindeyer that I admire so much. And he said that if you change the way you look at things, the things you look at change. So thank you very much. I leave you here my contact in Instagram if you want to share something with me. And thank you. Namaste.
Thank you, Dr. Yuli, for that fantastic presentation. Your passion to orthodontics, to your craft is obvious with the fantastic cases, the biomechanics, the photography that you showed. On behalf of the President, the other office bearers, and all the members of the Indian Orthodontic Society, it's my proud privilege to present you with a certificate of appreciation. Thank you so much for joining us today and spending your valuable time with us.
Thank you. Thank you, Dr. Siddharth, and thank you, Team iOS, and thank you, Dr. Yuli, for a wonderful lecture. Let's all meet next Saturday for the next iOS webinar series. Thank you all. Good night and take care.
भारत हमको जान से प्यारा है, सबसे प्यारा गुलिस्तान हमारा है। भारत हमको जान से प्यारा है, सबसे प्यारा गुलिस्तान हमारा है। सदियों से भारत भूमि दुनिया